Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people. And the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places. I'm joining from the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. If you wish, please share the lands from which you are attending in the chat. It's a privilege to connect, live, learn here, and I'm grateful to the traditional caretakers and owners of these lands. And I'll pass over to Christy.
Thanks, Lee. Yeah, my title's a mouthful, and it's just a title. So I'm Christy Newton. I'm the Associate Vice President Health at UBC Health. I am joining from my home office in what was called Semamit, and is now called Port Moody, the traditional unceded shared territories of many Coast Salish nations. And for those of you who may be new to the network, of perhaps first joining, and for those, it seems like a while since we last met, just a bit about the TBC at UBC Network. It is supported by UBC Health, which works under the Office of the Vice President Health at UBC. And the aim of UBC Health is to help address complex challenges affecting the health and well-being of individuals, of communities, and societies. UBC Health is a strategic unit, not an academic unit in the university, with a mandate to facilitate and enable collaborations across disciplines, faculties, external partners, and communities. And it is through collaboration that we aim to improve the ways we train people, develop knowledge, and shape policy to ultimately address inequities and improve the systems that foster and support health. The TBC at UBC Network itself convenes health professionals and leaders, community members, academics, and policymakers to bring forward questions and ideas important for team-based care in British Columbia. The network supports and complements province-wide efforts to enhance team-based care in British Columbia by focusing on education, research, evaluation, and knowledge translation by enabling participants to connect and learn from each other. Lee?
Thanks, Christy. So we'll start today with two quick Zoom polls to get a sense of who's joining us and what you hope to gain from this session. Please take a moment to submit your responses to the polls, and then we'll take a look at the results together. Both questions come up together if you scroll down in your window. I think everybody, we should have most of the answers coming in. So for the first question, which perspectives do you bring to the conversation today? Looks like we have a number of health professionals and clinicians in the room and folks from our health professional associations with a sparkle of faculty, staff, students, and health administrators joining us. So thank you. That's great for the conversation. We've also got a researcher and someone categorized as other. And for what you hope to gain, I love that this is all the way through. So learning, knowledge sharing, building connections, inspiration and motivation. and exploring resources and support take the lead after learning and knowledge sharing and collaborating with peers. Thank you, everybody, for taking the time to do that. So today's session is an interactive discussion on building intentional alliances among providers from different professions working across organizational silos. Our panelists will share their experiences, successes, and strategies for effective teamwork, with a particular focus on social workers and primary care providers working together within a primary care network. We'll explore trust, respect, communication, and collaboration, including differences between rural and urban settings and the impact on care for marginalized populations. We want this to be an engaging session, so there will be opportunities for discussion, reflection, and sharing your own insights throughout. In terms of structuring the session, we'll begin with a presentation from our panelists, which will be followed by a short panel question and answer. From there, we'll move into breakout rooms on 3 themes: research, education, and practice and innovation. And you can choose which breakout room you wish to go to based on your interests. And then finally, we'll reconvene as a large group at the end to share highlights from each breakout room and discuss ways to continue these conversations moving forward. And then just before we get started, we're also trying something new today. For this session, we'll be using both the Zoom and Slido polls to gather a few reflections from you at 2 points. Once after the panel discussion, and again before we move into breakout rooms. Only the word cloud question will be displayed. The remaining questions will not be shown live. They're anonymous and simply help us understand what's resonating with you and how we can continue improving our future sessions.
Thanks, Lee. Yeah, I just really want to reinforce that. You know, we've tried in the past to have sort of post network surveys. We've had variable responses to our post network surveys for feedback, and so we're trying to embed the opportunity to receive feedback right within the session, which is why we're going to try the Zoom questions and also the Slido questions. And we're also looking forward to developing a word cloud to sort of display our learnings immediately in a novel format. So, and that's enough of all the business of this session. Let's get into the actual panel presentation. So I am pleased to introduce our panelists who bring important expertise supporting team-based care in primary care settings. First is Casey Laviolette, a registered social worker based in Gibsons, BC. He's been deeply involved in developing social work within primary care in British Columbia, including through his work with the Sunshine Coast Division of Family Practice and social work associations. Casey also educates social workers with Vancouver Coastal Health and brings a broad range of experience across different roles supporting patients and teams. Next, we have Kelsey Yarlett, a social worker with the North Shore Primary Care Network Mental Health Support Team. She works closely with primary care practices on the North Shore, providing mental health and social work support to patient panels through an interactive, team-based approach across organizational boundaries. Kelsey also has a background in acute care, long-term care, and community settings. And finally, on the panel, there's Dr. Eliza Henshaw, who has over 20 years of nursing experience, currently serving as a nurse practitioner in primary care at Canopy Health in North Van. She's also the executive director of the NP Provincial Initiatives Program at NNPBC. Eliza's work spans many areas, including refugee medicine, mental health and addictions, and Indigenous health, supporting primary care teams and their patients in diverse settings. So please join me in welcoming our panel, Casey, Kelsey, and Eliza. Take it away.
Thanks, Christy. That was a kind introduction. So yes, my name is Casey Laviolette, and I'm here in Gibsons, BC, Squamish territory. I'll start by giving a very brief overview of where we're at and how we got here. So as many of you know, we've seen an explosion of new social work positions in BC over the last 5 or 10 years. Primary care networks have turned into really an essential component of how health care is delivered in communities, and social work often features prominently in these PCNs. The BC Association of Social Workers, where I was previously vice president, was a key partner with the Doctors of BC, the province, and many divisions of family practice in developing the role of social work in PCNs. And it has emerged as one of the most popular and common professions requested by physicians and nurse practitioners in primary care. Next slide, please. So what's really exciting about primary care and social work in particular is the huge variation in scope across BC, interior to coastal, urban to rural. Unlike acute care social work, for instance, which looks pretty much the same hospital to hospital, primary care social work can focus on counseling, mental health support, working with children and youth, working with vulnerable seniors. It is sometimes embedded in First Nations communities. What's common, the common denominator in PCNs is that providers, so the physicians and nurse practitioners, will often identify social work as essential in the delivery of quality care to their patients, and they will co-develop that role with the social workers to tailor it to the needs of the community. Next slide, please. My own experience in primary care was working on the Sunshine Coast for many years, both with the Division of Family Practice and later with Vancouver Coastal Health. So I'll talk a little bit about what it looks like in the rural context. Rural social workers in PCNs are often the only community social workers across maybe several towns. So their scope might expand to include more complex patients or maybe longitudinal care from birth to death. Quite a few rural PCNs are direct partnerships with First Nations who may even act as the employer instead of the health authority. Rural primary care networks tend to have fewer staff, fewer allied staff. And so the opportunity for social workers to be embedded and co-located in those clinics might be more realistic than, say, creating a new site in a hub and spoke model. These small communities may not have local social work leadership, and so or it's often available only virtually. So the risk of isolation and burnout and practice drift is real. So while that may be a bug in the system, the feature of that isolation is that, or the benefit of it, let's say, is that social workers and the allied staff may lean more on their physicians and nurse practitioner colleagues and that is the team versus the health authority or the First Nations team being more of the team. So the partnerships between the allied staff and the physicians can be and often is much stronger. And so now I'll hand it over to Kelsey and Eliza, who can talk a little bit more about an example of working together.
Thank you, Casey. So we just thought we'd start with giving an overview of how Eliza and I come to work together, considering we're in different organizations. So once her clinic was onboarded with the primary care network, we then had an overview meeting where the clinic was introduced to me as their mental health clinician. So it's the same person that they'll be referring to each time. And we have some huddle meetings so we can get to know each other over the course of a few months, to check in, to see how things are going, answer questions, just continue to build that relationship. If the doctor or nurse practitioner identifies they have a patient that could benefit from counseling support or perhaps resource navigation, they can then refer them to our mental health support team. And then we have 3 points of contact with the referring clinician at that point. So we let them know once we've scheduled an intake with their patient. Then after that intake appointment, we'll send a letter explaining what our plan of care is going to be, what's going to be the focus of the work together. And then you can offer them 8 additional counseling sessions. And by the end of that program, when we go to discharge, we'll send another letter explaining what we worked on, sort of a summary of what happened in those sessions, and that the referral is now closed.
Thanks, Kelsey, and thanks everyone for the lovely introductions. It's a real pleasure to be here today with all of you. I've been tasked with speaking to the NP experience. So I have lots of experience working within health authorities and in other roles, but I'm going to speak to my experience of being a PCN contractor in a PCN contract. Top of mind priorities when an NP steps into one of these contracts is understanding new clinic processes, intaking hundreds of patients. So just to be pragmatic about this, a full-time NP contract is a minimum of 1680 hours. You're intaking 1,000 patients. So our basic, math tells us each patient is going to be they'll have about 1.5 hours of access of your time per year. There is no extra time in contracts outside of that for things like admin, team meetings. So there's some upfront work with managing patient expectations and establishing all of your workflows. Signing a new contract, you're in a new setting. So understanding community patient flow in terms of public health, specialty care, etc. So I personally found that receiving this lovely structured orientation in this way was very, very helpful. I felt, I wish that all of the teams and services across my region would provide this service. It's kind of like meeting a patient for the first time. It's really helpful if you can be methodical and thorough and just set the stage in the relationship. And that's why we called this presentation Designing the Alliance. That's a term that's from coaching, whereby you sort of scope out the pragmatic elements of a relationship. How are you going to get in touch? How are you going to communicate? So this process was wonderful. Next slide. So we wanted to speak very generally to a case example. So what's actually happening on the ground? How are we communicating? How does this process work? So we can imagine that a patient comes into care. We can imagine that there's some complexity, medical concerns, a mix of mental health and medical concerns, maybe some socioeconomic concerns. During that first meeting, we would talk about the approach to medical concerns, prescribe medication, get an understanding of history, priorities, previous care provided, talk a bit about housing, income status. And at that point, if I felt that social worker support was indicated and helpful for the client, I would get consent from the patient to refer to Kelsey's team. In this scenario, we talked about generally a patient might need support for their mental health, maybe some income support. I think I sent, I made a referral just like this last week for you, Kelsey. And at some point, Kelsey and I would connect to talk about the case. Usually our communication was through email until I realized that I could give Kelsey a dummy PHN and then she can just book right into my EMR record. Or she can call the MOA. We can find a time to talk about the patient and make sure that we both understand each other's perspectives and we have a good path and a good way forward in supporting the client. Anything you wanted to add, Kelsey, just to share your perspective?
I think you captured it well. And I guess in a lot of cases, I might be offering counseling support to the patient, and we would just have the regular amount of communication, those 3 letters, just to kind of inform what's happening. In other circumstances, it can be much more complex. There can be paperwork that needs to be done for ministry supports. And in that case, we really need to collaborate and work closely together to support the client to fill out these documents and make sure that they'll get approved for support. So that would be an example of a time that we would need to connect and have a more in-depth conversation. and sometimes with the client present as well.
Thanks, Kelsey. Next slide. So just this is just summarizing what has worked really well for us. Keys to effective collaboration, so structured communication, direct responsive contact, role clarity and scope understanding, mutual trust and respect. Something about the slides doesn't really capture the delight of connecting with someone else and being with another human when you're trying to support a client who's perhaps going through a difficult time. But just to put this into my own provider experience, speaking to the concept of designing the alliance as nurses, and I know I was introduced as Dr. Eliza Henshaw, that's because I'm a DNP, a doctor of nursing practice, so not a physician. But as a nurse, we're educated within a team-based care model from day one. So we move through acute care, working with social work, OT, discharge planning teams. So all NPs have this experience and they've worked through their postmaster's degree, but we really share this in common. It's our nursing knowledge. So the foundation on patient-centered care, awareness of the patient lived experience, the world that they're in. So ideally our NP clinical work will build on that. And I've learned as a primary care provider that it's really important to take the initiative to build these relationships because they're very high value in terms of patient outcomes and also provider experience as well. And I think that's it for me and Kelsey.
I'll just speak to what makes our working relationship work so smoothly is a lot of that direct communication. You mentioned before how you figured out how to give me the dummy PHN so I can book into your calendar. Having that direct contact makes a huge difference. I have over 20 physicians and nurse practitioners that refer to me, and certainly the ones where we make it easiest to connect end up referring the most, and it just makes a huge difference to be able to collaborate more, to understand each other's role better by having those touch points.
Is that a wrap from the panel? Excellent. You mentioned I'm going to ask a question, but then we have a set of questions that that we will put to the panel as well. And that my question was, again, it was related to the very pragmatic piece you said about the amount of time you have per patient as a primary care provider. And then you mentioned, this sort of clear way of communicating. And is that included in your patient care time? Where is that? Or is this part of that administrative burden that all of our primary care providers are loaded with on top of their sort of defined contracts?
Is that a question for me?
It's for, I think it applies to Kelsey too, and I think it applies to both social work contracts and MP contracts, FP contracts in these types of structures.
So there's direct and indirect patient care, and all of that is included in those hours. So there's nothing outside of that. So all of communication, emails, et cetera, everything would be included in those 1680 hours.
Okay, so that is included in indirect. So yes, that's the piece. Got it. Thank you for clarifying that. Because
So 1.5 hours per patient, and that's direct and indirect. Everything is in that. Yeah.
Yeah, it does make you realize the squeeze on actually providing that sort of face-to-face stuff. And so making these efficiencies in the indirect processes as smooth as possible is great, which is why I love this, right? That you get it down to reducing it from half an hour or an hour of calls trying to figure out these connections to kind of a seamless approach. So this is great. Now we have a set of questions that we're gonna ask you, and we still have at least 10 minutes to go through them. So this is great. Um, so first question, and I think it's open to the entire panel. What ways of working have you found that improve teamwork with other providers who have patients in common with you, especially across organizational silos?
I don't mind going first.
Okay.
So I talked about co-location and being embedded, and in my experience, that was really a game changer, is being there in the office right beside the provider, using the same electronic medical record, being able to send each other messages, being able to read each other's chart notes, or just being able to walk over to the lunchroom and say, "Can I have a quick question? Can we just chat about this patient?" So that, I mean, that really improves patient care, but I think what improves teamwork, so like a secondary benefit of being in the clinic is that you're part of that team culture, right? So you're having birthday parties together. You're going on Christmas or holiday parties together. You share your lunches together, and so you're really building that trust. And I think being able to trust who you're referring your patients to uh, is super important.
That's great. You know, we talk about co-location as being key. I do think it's co-location with shared space because there are some co-located, and they think of it as the same building, but they're really professionals working in parallel. And then I think you also mentioned that shared documentation opportunity. And I do think that there's co-location and then there's enhanced co-location because it is that opportunity in the lunchroom or the corridor where you do have those bumps that you could ask those questions. And then the shared lunchroom for birthdays and potlucks and things like that are always great. Sorry, I jumped in. Anybody else on the panel want to talk about that first question?
We don't necessarily have the benefit of co-location with our programs. So I find what's really helpful in building the relationships is when we do have those huddle meetings or those opportunities to connect. Like anecdotally, I notice the providers that show up, that ask questions and want to have those meetings are the ones that will refer more often because we've built that relationship. They know what we offer. And I try, especially with like the discharge letters, to show, this is what we worked on. These are the services I referred to. So that it demonstrates, what this program is about and might encourage more referrals in the future. So that is another way. And then just, yeah, having that connection as much as possible, the ability to connect easily, since we can't just find each other in the hall. Do we have a way of just calling directly? I always give out my cell number. I always give out my email so that providers can come to me directly. They don't have to go through admin and get caught in this phone tag process. We can just sort of reach out and connect and make it easy.
Agree, Casey and Kelsey, with all the things you've mentioned as well. Christy agreed that there can be really high functioning teams that are separate from each other, that are co-located, that are not truly integrated. But I just would say my reflection is like it really shouldn't be this hard. Like there should be one centralized patient medical record and a triage system in place to direct patients to the correct provider with one record of truth. The current system is super inefficient. It's very expensive, poor provider and patient experiences. That said, we are in the system that we're in. So I would say we need to use our agency to build relationships. We need to take extra time to lean in and co-design how to make processes work. We really need to be proactive and create structure. And then, of course, the context of that would be like the enemy of progress is perfection, right? So we're going to have to adjust and refine as we go.
Yeah, that sort of agreement to learn together, right? Um, and I do think you've all talked about building that relationship where you get that comfort with learning together. And so any ways you can think of, um, that will support building that relationship and that comfort of learning together and co-creating your next solution, I think is great. Do you want to move on to the next question, or is there anything else on that one?
I think you can move on.
Okay, so I think we can move on. The next one is, what prompted you to build these relationships? Was there any specific motivation to connect, to think about these processes differently? What wasn't working?
So before I started in a PCN contract, I'd always worked within an interdisciplinary team before. So Ravensong Community Health Center in Vancouver, worked there for 12 years, Bridge Refugee Clinic, and then with the Tsleil-Waututh Nation and their interdisciplinary team. And so part of that work was working with outreach for intensive case management for youth. And I always worked with a social worker, and my best clinical moments were always when a social worker was involved with the care. So starting in the primary care landscape where team-based care was not the norm felt a little bit panicky to me, because my care is not going to be as great because I don't have that depth of knowledge and expertise. So for me, what motivated me was just knowing that there would be better patient outcomes. I would have a better provider experience. Also, like selfishly, a better volume of patient visits. Because Kelsey sees a lot of patients for mental health counseling. I don't always have capacity for that. And also, my patients are just a lot calmer when Kelsey's involved in their care. They're calmer. I trust her. So just better outcomes for everybody.
First of all, Eliza, thank you for your kind words about social work. And not every provider, I think, has the same experience that you have had with social workers. My I think what prompted me, and it wasn't driven exclusively by me, how we co-located, but my reason for wanting to be present with physicians and nurse practitioners, I think, was because social work as a profession is unique in healthcare, and it's often misunderstood. And so trying to really promote the vast array of things that we can do, sometimes having joint visits with NPs or physicians so that we can observe each other, and I can say, look at all these things I can do, and wow, you do that too, and like, oh, we have these shared values, we have these shared patient approaches. So I think being able to demystify social work and then make it more of an appealing, person to refer patients to, was part of what drove me.
My education also really centered around interprofessional education. So I think that's always been just the baseline of how I operate. But of course, for our program to function and exist, we need referrals from nurse practitioners and physicians, family doctors. So ultimately, I believe in this program. It's so helpful for patients. They get free counseling, which is so rare. So by fostering those relationships and building my relationship with the referrers, then I can see more people, I can help more people and help them to have better outcomes. So that ultimately drives me to keep building the relationships and having positive outcomes for these patients.
It's really nice to hear the experiences during training and experiences with interprofessional work. And because we're really working hard to develop, to improve both classroom-based, but also practice-based interprofessional training so that you can hit the ground running when you graduate. I'll be honest, I did my training in Ontario, and uh, immediately upon graduation, I worked in a family planning clinic that had a nurse practitioner, an RN, and a social worker with these youth and the family planning clinic. And then I moved here, and everybody was not working collaboratively like that. I couldn't find it anywhere. And I think that's part of what, again, motivated me to go along the lines of scholarship that I ultimately did. Um, So I'm glad to hear that you've had those experiences and that you've been motivated enough to pursue, to push for change. And so that's great, and I appreciate you championing them. We have one more question, and I think we have, if we do it quick, I think, it's kind of related, but were there any specific circumstances or factors that helped create or strengthen your relationship? Was there any specific things that triggered it? Any meetings at a conference? Any, um, I don't know.
For me, nothing that hasn't already been mentioned.
You're making me feel guilty on your treadmill, by the way. I should be walking on myself.
I think I really have to give credit to our local division of family practice, where the board members and the staff were really, really prioritizing team-based care when they were putting the PCN together, and prioritizing social work, but having a lot, like so many meetings between providers and allied staff beforehand to do like visioning of what we want this to look like. And yeah, I think that was essential in making it a successful PCN.
That's a great shout out to your division, and perhaps a call to action to some of the others to see what they can champion. Okay. Why don't we get ready to move into our breakout session? Um, and this is where we're going to ask the participants to take a moment and answer a couple of Zoom poll questions. And again, your responses will be anonymous. They will not be shared live. This is really just for us to look at how we can improve the work of our TBC at UBC Network, and make sure that we're really addressing your needs as we move forwards with different presentations and different topics. Uh, while you're filling that out, I am going to say that as you're thinking about interesting topics, we have a call for panelists for future network events. So if you have a practice innovation, some research, an educational program that you would like to share that will build team-based care in the province, please submit an expression of interest form, which we will post in the chat, the link for that. Thank you for answering the poll question. And again, feel free to express interest in presenting. We're always looking for new topics to share. These are our breakout rooms. There are 3. You can choose the one that best align with your interests. And there is breakout 1 is research. Breakout 2 is education. Breakout 3 is practice and innovation. And hover over your breakout room icon, which may not be in the bottom. It may be in the dots of more on your screen. And then click on join. Those instructions will be in the chat as well. And again, another thing that we're going to try for the first time this session. So before you join the breakout room or while you're in the breakout room, we're going to ask you to, or invite you to join our Slido poll. And there's a QR code to join. Um, and there's also a link in the Zoom chat. And the first question on the Slido poll will be a one-word takeaway, and it will be forming a word cloud for us to look at when we come back from our breakout rooms. So you have until the end of the breakout rooms to address the Slido questions. And then the other Slido questions, again, are anonymous and for our improvement. So if you would join that, that would be great. We will come back at 1 p.m. We'll hear some highlights from each of the breakout rooms. And the breakout rooms will not be recorded. Just the main session is recorded. And yeah, so if you have any trouble, just linger and we'll give you a hand to get into a breakout room. Otherwise, we'll see you back here in about 15 minutes.
It was the conversation in the room that I was in was so excellent. It was amazing to hear so many thoughtful and innovative ideas. I think we'll take a few minutes right now to share back just the highlights from each of the breakout rooms, inviting each of the facilitators in those rooms to share those highlights. Looking at Christy and Ben, maybe I'll start from my room since my room was number one on the list, our research room. And the question that we explored in that room was, how do we build and enhance the evidence base for this relationship building between providers? And a couple of key pieces came up in the conversation. One was first looking at, when answering the question, how, thinking about recognizing that a lot of the work happens on the side of providers' desks. And so what are the collaborative structures and systems that could provide assistance or support for doing this work and doing this research? And how do we continue to grow and generate those? Another question that came up was, why does TBC work, or how does team-based care work? And some stories were shared about work that's starting to develop in the Division of Family Practice in the South Island, recognizing that so much of our research is oriented to the quantitative lens, and in particular to exploring the cost utility when we're talking about funding and the work of the ministry. And other important things to explore include lessening the burden on clinicians in the team-based care environment. Are patients receiving higher quality care? And at the same time, are we asking patients and clients about team-based care? So in the terms of, do they know that what's available in these team-based clinics or primary care networks that they might be a part of? And so really the highlight here is, how do we begin to shift both the lens and the questions in research to experiential, combining both qualitative and the economic considerations together? And how do they speak to one another? Two more pieces. One is, what initiatives are we evaluating? Really important. So where we're starting with a remark that so much focus up to this point has been on patient attachment. But the consideration that perhaps that's an oversimplification of the challenges we're aiming to address, which may include mental health, provider burnout, the relationship pieces that providers are getting out of it, what keeps us doing this work. And then that led to the question about, what are the enablers of relationship building, and preparing providers for the challenges that come up. So how do we prepare clinicians for these challenges in team-based care? And that's that. Thank you for everyone in my group for that great conversation. I hope I've captured it well. And maybe I will pass from here to Ben or Christy.
I can go. So I was in breakout room 3, practice and innovation. And the question that we were pondering was what ways of working have you found that improve teamwork with other providers who have patients in common with you across organizational silos? And a big focus was on communication. So, an example was given right off the bat of from a social worker working in the community who had a patient who was seen in the UPCC, and the social worker in the UPCC managed to connect with the community social worker. And so they were more efficiently using resources than having the UPCC social work engaged and also the community social worker engaged with that same patient. So just reaching out and connecting, I think came across as a really big one. We also had someone from the who's working with specialist consultant teams that are newly developing, talking again about communication and a really interesting observation on sort of hard communication strategies and then those sort of soft, sort of day-to-day huddle type communicate informal. So formal and informal, I guess, is a better way of describing them. And finding that the ones that stuck more were the informal ones. So which led me to think that perhaps ensuring that we have both, I think both are required, and that we make time as we're building teams or teamwork processes, that we actually build in time for these communication opportunities that occur. Then there was a bit about working across professions, not necessarily organizational silos, but thinking of professions that cover a similar population. And we were thinking about mental health. So there's clinical psychology, there's counseling, there's OT, there's NP, FP. So how do you work across those professions that can provide similar types of care that you want to make sure there are no gaps, so nobody assumes the other is taking care of it. And then there's also not, I guess, a sort of disrespect in duplicating and making sure so doing the same thing or covering the same ground. And so that was more of a question on how to address that or how to facilitate that. Um, and then another point that came forward is also, I think, communicating with our patients about teamwork, and engaging the community in this shift in care and how do we do that efficiently and ensure that we're bringing everybody along in a trusting, respectful way. Did I miss it? I'm going to ask my group because we really didn't identify somebody to report back. And so I'm capturing what I can recall.
I'll highlight Emily mentioned working with Leslie Lutz on studies related to this and the UBCO Psychology Clinic. So just a really valuable sort of insight into the questions and the learnings there.
Yes, thank you.
So I can go next. I was facilitating breakout room number 3, and our question was, how do we train people to do this relationship building ideally? And interestingly, I was coming from an educator perspective, and we had some conversation that we're probably doing a better job with students now than people currently working. But there was a really good point that in teaching students, it's really important to help them understand that some of this is really context specific. There's not just one model of doing this, and so that depending on the context they're working in and understanding that it's going to be unique in every setting. And then we talked about sort of current providers, and there were some ideas around just education around team-based models of care, and then we really talked about the importance of those opportunities for face-to-face relationship building, but that even when other organizations have created those opportunities, there's still practitioners that don't have the time, that because of workload, that sometimes those aren't always well attended. So and so there was a question around funding, and so I think Eliza and Kelsey talked about sort of pre-huddle meetings, but I think we were curious around, were people paid to attend some of those huddle meetings as a group to sort of get to know practitioners? So that's the high level. From my group, Casey, anybody else? Did I miss sort of the key points of what we discussed?
I think you nailed it.
Thanks.
Kelly, Christy, thank you for sharing back from your groups, and thank you everyone for the engaging conversations. We'll move into some conversation in the room next. We have a couple more kind of questions to talk about and to ask. But before we do that, let's take a moment to look at the word cloud that you've all been contributing to. The question you responded to was, in one word or phrase, what's the main takeaway for you from today's session? Looks like relationships comes out as the clear lead in this, and the value of relationships, additional themes being enhanced co-location, common sense. I love that. That makes me, I see Christy laughing. That makes me think of the, it doesn't have to be more complicated than it is, or keep it simple. What's common sense? Collaboration, relationship building, and culture. So important. So thank you for taking the time. Oh, it looks like we got a couple more coming in. Might grow the words. If you think of anything else, this isn't the end to filling out the word cloud. Through the next 15 minutes while we're continuing our conversation, please feel free to jump in and add more to it. We send out summaries a short time afterwards, so we can include the word cloud in the summary of the event that we send out. And that brings us back to conversation just within the room. We have a couple other questions to toss out to see what people think. Is there anything that came up during the breakout sessions that folks, maybe this is where we'll start, that folks want to talk more about or bring into the wider group? This is for anyone, participants or panelists. Ben.
It's a question I think that people were talking about warm handoff as an ideal, and thinking of, and I think the context of this session is about when you're not co-located, when you're on different EMRs, when you've got all of these sort of dividers between you and people who are also caring for your patients and clients. what is what does a warm handoff look like under those circumstances? Like, how do you adapt to and what's the ideal there when you won't see each other face to face, and you've got these things that are very indirect ways of connecting.
Kelly?
Mine's a separate question, so I'll wait for if anyone wants to respond to Ben.
I'll respond. Recently, with all of these new, we were booking Zoom meetings and things like that. People sometimes just pick up the phone and call, or text. It's like, can I talk to you about this patient? That we have in common, or that I think would really benefit from working collaboratively on. I think we've become fairly sort of, I find, formal in our, a formal consult or a formal, and sometimes it is just a reach out to say, hey, can we connect on this? We need to go back to the good old days where Zoom didn't exist and phone calls and text messages were the way we could communicate. Eliza,
Um,
go ahead.
oh,
Oh,
sorry.
Casey, go ahead. Yeah.
I don't have to go now, but okay, I'll be quick. So I think yeah, even if you're not co-located, you're not using the sh same EMR, I think there's a way of talking to patients and including patients that is part of the philosophy of PCNs, right? So instead of just saying, "Okay, I got this referral, looks like you have such and such diagnosis, let's talk about that." It's okay, so it sounds like you and your provider have been talking about this. You thought it was serious enough to refer to me as a social worker. Can you tell me what those conversations were like? And I'm going to be sharing my thoughts with your provider. So, what, how do you want this to look? How do you want us to communicate about this? And so really like including the patient in the care team. That's the vision of primary care. And then by doing that, it has the effect of, I think, highlighting and prioritizing that each of the other members are really important too, that you're sort of respecting each other's profession. And it kind of flattens that hierarchy a little bit.
I'll just jump in and also lower my hand. I did some learning modules. I think it was through the Alberta Health Network on trauma-informed practice. And what really shifted for me was that we are great at providing trauma-informed care to our patients, but we are not great at providing trauma-informed communication within all of the disciplines. And we need to consider that if you're talking to a primary care provider or social worker, likely they've gone through a significant degree of vicarious trauma just by being in this work. So adapting a mindset and holding a space of kindness is really important. If you speak to someone and they are going really fast, they might just be in fourth gear because they have so much to do. It's not personal. They're not trying to be dismissive. They don't think their discipline is more important than yours. They literally are just trying to survive and provide excellent care. And it's like going in different tracks when you're walking beside someone who's going on the little the walking pad at the airport, right? Like some people are just, they're required to go really quickly. And I think that just as a baseline, taking a minute to give someone the benefit of the doubt, if they're a little snappy, they're a little dismissive. If I speak to a radiologist and they're like, sorry, I don't really think you need to make this call, I'm going to just guess that that has more to do with their day than with me. So just having that approach for all of everyone who's involved in the care team, not just the patients.
So important. I think about the warm handoff piece, and we've heard more and more over the last several years the phrase, you have to go slow to go fast. And I've been thinking about uh, like like interrogating what does that mean? Like not just intellectually, but in our practice. And it's about slowing down to the speed, I think, the slowing down to that speed of relationship. And for me to do a referral or to connect with someone who I may not have met before looks different than if I were to send somebody over to see Christy, who we've been working together for years. And so I think I think about it's not one answer for every relationship. It's what does this relationship need, or what does this consult need, and that reflects the both experiential but the nature of kind of complex systems, which is how do we adapt our approaches for different circumstances. Kelly, you had another question earlier.
I was going to say, I think this comes back to relationship, right? Because we're much more likely to give people the grace. I think of a team that I work with, and I went to talk to a surgeon, and he was up to his eyeballs in referrals, and he's like, I can't see that person, but because I know him, because we had a relationship, you're able to kind of recognize he's venting, he's frustrated. It's not about, it's not that he doesn't care about my concern about how long this patient's waited. And so I think to Liza's point around trauma-informed communication, it all comes back to when we do have relationships with people, I think we're able to give sort of some of those graces a little bit more and understand where people are coming from in those moments. My previous question was just for Liza and Kelsey, and this was just a little bit around your processes. Kelsey, like your scope of practice, Eliza mentioned that, housing and there was other issues. And so I'm curious if Kelsey, there was sort of resource navigation or case management as part of your scope. And if not, if there's things that come up, Kelsey, can you refer back to Eliza? Eliza, do you have other professions if it's sort of outside of Kelsey's scope to refer? Like, how does that, when we refer, but sometimes things come up in a referral that we have to go back to the primary provider to say, hey, it sounds like somebody else needs to be involved.
Yeah, so our program is technically mild to moderate mental health concerns. So often we'll get referrals. We'll meet the client, still do an intake, and then decide that maybe they're not within the scope of our program. But thankfully, like we're located in the Hope Center in North Vancouver. There's other teams here. So we have also those relationships where we can kind of talk to those teams and say, oh, does this person sort of fit with your program? And then go back to the primary care provider and say, can you refer to this program instead? And those are often really great opportunities to build rapport and a relationship, as well as just offering different service that might be more beneficial for their patient. And we will do resource navigation as well. So we do see clients for housing concerns, like income issues, financial as well. And people can get re-referred for service. So it's not just those like 8 sessions and that's it. They can come back. So if someone does have more complex needs or they change over time, we can sort of keep seeing them. And it's not exactly case management, but sometimes it might look a little bit like that for certain clients.
Thank you.
I can just add to that, Kelly, thanks for the question. I do see a lot of patients who are firefighters, teachers, nurses, RCMP. So I do use those existing pathways if they're sort of profession based, just because I really want to protect resources for people who aren't equipped or don't have other pathways.
Any other questions that came up during today, either the panel session or your breakout sessions? Anything that is still a bit of a gap? We're looking, I'm gonna comment in the silence, and then I think we'll wrap things up. As I think I mentioned, we're building a gateway team-based care teaching clinic on UBC campus, and it's associated with a Center for Innovation in Collaborative Health Education and Team-Based Care. So an opportunity to actually research and share, maybe through the network, things that we learn within the teaching clinic, and also just innovations and ideas about team-based care. And this session has made me think that one of the areas of research that we can look into and share is, in different contexts, how do you build relationships so that can then facilitate that care? And I think I'm gonna think about that. I look at some of our really high functioning teams in this province are in rural communities where you likely have a relationship with your neighbor who then may or may not become one of your patients. And it's through that relationship actually that makes it really efficient as a team, because they all have in a small community, those relationships. In a large urban center, those relationships are more difficult, I think. And how do we build them? I also remember a program that we had, which is interprofessional rural placement program, where we placed teams of students in different communities to learn together with it on their placements, and they often lived in the same house, and it was what we termed in the presentation social demics. So instead of academics, it was social demics, and they were learning about the different professions and their roles on the teams after hours while watching a football game, or having dinner together in the shared accommodation. And so thinking about all of these different pieces that we have to build those relationships, celebrating a birthday in the lunchroom, making sure you have a common bump space in your clinic if you're co-located. Anyway, this is great. So it's given me an idea to take to the Gateway project and see if we can build on it. Kelly, last word to you.
I just, I know we didn't talk about this, but it just makes me think, as people talked about the various communities they came from, is also thinking about how we leverage relationships with community organizations that support our patients, right? And tapping in and building relationships beyond the sort of primary care network, but into the community.
Yeah, that's great. Okay, we're almost at time. And thank you very much to our panelists. Thank you to all of those who joined us today and contributed to the breakout conversations and the discussion and our word cloud. I hope that we have got some feedback on our Slido and Zoom, because we really do want to build this network to meet our community needs, our provincial needs with respect to team-based care and sharing. And we will be having our next event in the spring. So if you haven't joined our sort of email list, the link is in the chat. And please feel free to join, so that once we've got it figured out, a date and a topic, we will circulate that throughout our little network listserv. So on that, I wish you all a good afternoon, and happy holidays. We'll see you in 2026. Wow.